Good afternoon, everyone. My name's Bernie Croal, and I'm president of RCPath, and it's a great pleasure to welcome you to this educational webinar during National Pathology Week. The topic today is From Bench to Bedside and is a webinar in collaboration of the Royal College and Roche. There are various aims of today's webinar, both to highlight the vital role of diagnostics in the NHS, but to focus really on the long delay that typically exists when we take new diagnostic tests from the bench to the bedside. We have three excellent speakers, Nick Brown, Ian Godber, and Zane Jaunmuktane, who will speak for 15 minutes each. But first of all, I'm going to set the scene with a few slides over the next 5 minutes. Clearly, the starting point for any new diagnostic test or process happens in the research field. And typically, this is done in a research lab or in a small scale clinical trial involving that test. When we think about the processes involved, it was Archie Cochrane from the Cochrane collaboration fame who'd first described several decades ago the process that we should travel down as we work towards implementation of a test. Can it work? Does it work? And is it worth it? Can it work is usually done at the level of assessing efficacy of a new test. And this is usually small scale studies, which involve, for example, 100 patients with cancer and 100 patients without. And we carry out a new test and try and make sense of whether that test can tell us something about diagnosis or predict a new disease happening, or indeed be used for prognostic indication, or indeed treatment efficacy itself. So can it work is usually done small scale. It's done in research labs or small clinical trials. The next stage is the most important, and that is, does it work? And this is where we apply the test to our real life healthcare setting. And this is to assess effectiveness of that test within that actual setting. And as Samir Gray once pointed out, what works in Sloan Kettering may not work in Kettering. And it's crucial, therefore, that we test any new test or process within the actual setting in which it's going to be applied. And it may be that for whatever reason, the efficacy of a test which works well in a research trial doesn't actually work in real life. And this might be because, for example, the sample can't be transported to the lab in time, or indeed the test can't be replicated in different patient groups or in the populations that we're now testing. The final stage is when we move to, is it worth it? And this is incredibly important in the current cash-strapped NHS. This is where we try and assess whether the cost of providing that test is worth it in terms of either the outcome or the sort of healthcare budget in which it's applied. Typically, however, within the UK, we have significant problems around the next stage, which is a fourth stage, which I'll add, and that is about implementation. Because no matter what we do, there may still be significant red tape that stops us doing it. So if we imagine a new test, test A, being applied to a patient pathway, we may be able to prove that, yes, can it work? Does it work? Is it worth it? In the sense that it achieves either better outcomes for patients or improved use of resources. And by resources, we mean across the whole patient pathway, or ideally both of those. But despite that, there are still significant barriers, and we know many of those barriers. Lack of funding, lack of turning space in the financial area that stops us actually, doing something in order to do something else. Inevitably, silo budgets is still a big problem, whereby despite a proven benefit to the overall healthcare budget, the laboratory budget has to bear the brunt of the initial costs, and that can be a showstopper. It may be that we don't have a particular piece of equipment to carry out the test, or indeed space to put it. And of course, specialist staff inevitably are involved. And again, particular parts of the country may not have those staff. And increasingly, it involves IT staff as well. Despite our best efforts, it may be that there's not enough clinician support to make the test work. They may not want to bring it on board. They may not want to use it. They may not want to change their behavior in terms of the result. And this can lead, of course, to pathway failure, in which case there is little point in introducing that test. And finally, increasingly, especially with the regulatory changes that we see ahead, we may see problems that add further red tape, and lack of a mandate from either government or senior NHS seems to still be the case. So I'm going to stop sharing my screen now, and I'm going to pass to the first speaker. You have the biographies of all the speakers across the 3 talks today, so I'm not going to mention them other than their name, and you can read about them. And I'm going to start and hand over to Nick Brown, who's going to hopefully share his slides in a second. Thank you.
Thank you very much. So I'm just opening my slides now, and then I'll put them on full screen. And hopefully you can now see that. My name is Nick Brown. I'm a consultant medical microbiologist based in Cambridge. I'm employed by the UK Health Security Agency, but I have no conflicts of interest relating to this talk. Obviously, thank you to the organisers for inviting me to talk today. Now, antimicrobial resistance is a global issue that has potential to impact on all aspects of healthcare, and therefore indirectly or directly impact on almost all of society. And this is reflected in the fact that antimicrobial resistance sits on the National Risk Register for the UK alongside climate change and organised crime. Now, within the field of diagnostics, there are literally hundreds of new diagnostics being introduced into the AMR field. And what I'm going to talk about today is very much sort of cherry picking. Clearly, it would be impossible to talk about everything. So to start, I'd perhaps take a step back from what Bernie has introduced in terms of the origins of a new test in the research laboratory, and say that first of all, there should be a need. And I think with antimicrobial resistance, it's clear that there is a need. And on this slide, I've just shown the 2 key messages that came out of the review of antimicrobial resistance that was performed by Jim O'Neill, now Lord O'Neill, instigated by David Cameron when he was Prime Minister. And 2 key facts from that, that it is projected that by 2050, antimicrobial resistance will cost the world economy something in the order of $100 trillion per year. Now, that's an enormous sum that is too difficult to compute. My youngest son described it by saying that's lots and lots and lots and lots. So I think actually that sort of sums it up quite nicely. That is, in effect, the equivalent of the total GDP for the world for 1 year. And then in terms of mortality, it's projected that by 2050, antimicrobial resistance will cause 10 million deaths per year, which is more than cancer and road traffic accidents and some other major causes of death all put together. Recently, these projections were corroborated by a study that has become known as the Graham report, the Graham study, coming out from collaboration based in Oxford. And in fact, the figures that were projected by Jim O'Neill are probably not too far off the mark. That already by 2021, it's estimated that something just under 5 million people die with a bacterial infection related to antimicrobial resistance or associated with a bacterial resistance. And of those, 1.14 million die directly as a cause of the antimicrobial resistance. And clearly, we're some way off 2050 at the moment. Antimicrobial resistance is directly related to exposure to antibiotics. The more we use antibiotics, the more resistance will develop, and it's an inevitable consequence of exposure of bacteria to an antimicrobial agent. And therefore, the more you use an antibiotic, the less effective it becomes. There is a cycle, as shown here, of increasing use of antimicrobial agents, failure because of resistance, and the need to use more antibiotics. This slide comes from CDC in the States. But the thing I wanted to particularly emphasize is this bit here, ineffective empiric therapy. And now this shocked parliamentarians when it was presented at the Science and Technology Committee back in the early 2010s, as many people did not realize that when a doctor prescribes an antibiotic, almost always they do not actually know what the cause of the infection is, or indeed on occasion whether the patient has an infection, or particularly a bacterial infection at all. And this means that there's a likelihood of treatment failure, or that they've chosen the wrong antibiotic. And increasing resistance means that the likelihood of choosing the wrong antibiotic is increasing with time. And because of this, Jim O'Neill had diagnostics as a key part of his AMR review. And he described the problem very nicely in this diagram here, starting on the left-hand side, really what is happening at the moment. Empirical diagnosis, that means that often the wrong antibiotic is chosen and treatment fails and a new antibiotic is given. And indeed, on occasion, the right treatment may never be achieved. If you have a diagnostic test, then the current turnaround times for most tests are such that actually they're too slow to be able to inform that initial prescription. And he envisaged a situation where rapid diagnostic tests could be used at the point of care that could inform the prescription, therefore changing the current empirical best guess to an informed decision. And this was included within the final report as what he described as a challenge. I call on governments of the richest countries to mandate now that by 2020, all antibiotic prescriptions will need to be informed by up-to-date surveillance information and a rapid diagnostic test. He has subsequently said that he actually didn't care about the date, and obviously we're a long way past 2020 now, but he just wanted people to do something. Within the UK, diagnostics was included within the previous National Action Plan. We've recently just launched a new one with a specific commitment that by 2024, the UK will be able to report on the percentage of prescriptions supported by a diagnostic test or decision support tool. So if not actually implementing the rapid diagnostic test throughout the country, at least being able to measure it. And as part of that National Action Plan, a lot has been done. But I put this diagram up really just to summarize the two key components of that. So as the subject of this webinar, on the left-hand side, new innovation, new technology, new tests that will be developed to, I think, respond to the perception of many people that this new diagnostic test would have to be some sort of black box that sits on the GP's desk and gives him the answer or her instantly. But a big component of AMR diagnostics is, as shown on the right-hand side, improving what we've got already or making best use of what we've got already. And I'll just quickly give some examples of that. And this really fits into the bracket of diagnostic stewardship, which as a subject is really gaining momentum now. And if you do a PubMed search on diagnostic stewardship, you'll see the number of citations increasing exponentially over the last 4 or 5 years. Seen as a partner to antimicrobial stewardship, which, as described on the right-hand side of this slide, right drug, right dose, right duration. Diagnostic stewardship is right test, right patient, right time. And this, of course, is nothing new to anybody working in the pathology field. But we've traditionally divided this up into pre-analytical, analytical, and post-analytical phases of testing. So not new, but I think the new structure of this has gained some traction and has opened up the subject to others who wouldn't have been involved in it before. So right test, is the test appropriate for the setting? Will the clinical care of the patient be affected? And will the result be available in time? And I think this in AMR has become a key component. So reducing lab turnaround times, ideally by having a point of care test, has become the mantra for a result that will inform the antibiotic prescription. I could give lots of examples of the improving what we've got part of the initiative, but I've just chosen to use blood cultures because that's a specific example that has been taken up by NHS England at the moment. And I've just listed a whole range of different parts of the whole patient test pathway that could be open to quality improvement. And one that is a key component of the NHS England initiative at the moment is making sure that an adequate sample of blood is taken to increase the yield from the blood cultures. But I would argue that equally important is reducing sample contamination, because as with any test, getting the wrong result and a contaminated culture can easily mean that somebody thinks that a patient has a bacteremia when they don't. It is clearly critical, and a false positive result in this field means that a patient is quite likely to get an antibiotic for infection that they haven't got. Down at the bottom, I've also bulleted some newer initiatives that are related to reducing turnaround time. And today, initiatives to reduce the time it takes to identify an organism and then also get sensitivity tests are proving very useful. So what could a rapid test do? It could, first of all, show you whether you've got an infection at all. And very importantly, is it bacterial or viral? What type of infection is it? Does the organism have resistance to key antibiotics? And then what other antibiotics is it susceptible to? So this is a sort of pathway, if you like, of priorities that we would have for a rapid test. There are tons on the market. I pinched this slide from Till Bachman, but loads of rapid technologies have been launched, and many of them are now in routine use. Others are not, clearly, as we'd appreciate. And one of the reasons why not, it explained in this report that was published in 2015 from the Centre of Evidence-Based Medicine in Oxford, that there is often a poor evidence base to support the implementation of a new technology, a lack of clinical trial data and cost-effectiveness assessment, and a lack of research around the best implementation. Much of this would also tailor in with behavioral studies. A good example, MALDI-TOF. I saw a lecture on MALDI-TOF, which is mass spectrometry for the identification of bacteria, about 25 years ago. I remember at the time thinking, oh, this is really interesting, but I don't think it'll ever catch on. And then the cost-effectiveness argument flipped about 5 years ago, when suddenly the standard of care in the laboratory, if you like, the biochemical identification strips that were used increase in price. And MALDI-TOF suddenly became much more cost effective and now almost universally adopted within laboratories within the UK and in many places worldwide. Behavioral side aspects can be really important in terms of implementation, even when a test is shown to be very good. And I've just got one example here, which is pneumococcal urinary antigen testing, recommended in the United States in many federal states, Indeed, it's also recommended in British Thoracic Society guidelines for diagnosing pneumonia. But in this study, they looked at 170 hospitals, 160 eligible patients with possible pneumonia. The test was only adopted by between 15 and 18%, depending whether you're on a critical care unit or not. So the uptake was poor, even in a critical care setting. And although it was shown that a positive result would be helpful in reducing or de-escalating your antibiotic treatment, in 2/3 of the cases, the clinician ignored the positive result, and therefore the impact was low. The Longitude Prize for Antimicrobial Resistance was awarded this summer. This was a prize that was set up back in 2014, administered by Nesta Challenge Works, £8 million for the development of a technology that could impact on AMR. And this test, the PA100 AST system by Astrago, was the winner of the test. And I'm, as you can see in the photo in the top, a great celebration with the award. And just very briefly, just go through some of the issues with this test, because it's still not widely adopted. NICE guidance says that it should not be used in the routine setting because there are insufficient data, although it shows promise. A recent systematic review of rapid tests for UTI says that there is currently insufficient evidence to support the use of point-of-care tests in UTI diagnosis. And even a clinical evaluation of the technology recently published this summer, which was not really a clinical evaluation because they didn't evaluate outcomes, although it showed a theoretical benefit, was not able to demonstrate that it had clinical utility. So clearly a lot more data are required. So finally, just to sum up, what are the barriers? I've just chosen just 2 examples. The first, C-reactive protein in general practice. NICE guidance recommended that it should be introduced. And this review from the British Journal of General Practice just looked at why most practices have not introduced it. Funding, communication issues, disruption of the normal practice rhythm, concern about quality of results in the point-of-care setting, impact on budgets when, as we've mentioned, silos, that the test would have to be paid for by the GPs, but the savings are not realized by the practice. And then the need that this evaluation by Nesta Challenge Works on implementation, particularly in low and middle income countries. We need to reassess the concept of value, move away from this concept that tests need to be the same cost as antibiotics, because antibiotics cost pennies generally, whereas tests cost pounds. Need to focus more on where the greatest need is, need political will similar to that seen in the COVID pandemic, perhaps, and assess benefits to the healthcare system rather than just the individual patient. And just to finish, that was a very quick run through what is clearly a really huge area. I can't not mention sequence-based technologies and metagenomics, but also think that in the future, AI will become important, and also perhaps the need to repurpose technologies for alternative uses. Just as one example, rapid tests diagnosed for blood cultures, why can't we use them for urinary tract infections or infections elsewhere? And I'll finish there. Thank you, Ben.
Thank you very much, Nick. Excellent. I'm going to ask you to unshare your screen and bring the next speaker in, Zane, to share her screen. So Professor Zane Jaunmuktane is a consultant neuropathologist who's going to speak to us around the topic of dementia and Alzheimer's disease.
Hello, everyone. My name is Zane Jaunmuktane. I am academic neuropathologist based at University College London, and my academic interest is particularly on dementias. So dementia the prevalence of dementia in the UK is projected to reach 1 million by 2025 and keep increasing in numbers as the years go by. And the reason for that is that it's due to the aging population and increasing life expectancy, both of which are significant risk factors for the condition. This inevitably poses substantial challenges for healthcare systems and society. The economic impact alone is staggering, with combined costs of healthcare, social care, and informal care provided by family members estimated to reach around 40 billion per year. Moreover, up to 100,000 people with dementia in the United Kingdom are under the age of 65, which further strains the workforce and economic productivity. Beyond these financial implications, dementia places also a profound emotional and physical burden on patient families, friends, and caregivers. Managing the dementia involves complex long-term care, putting immense pressure on the NHS and social care systems. The development and implementation of diagnostic technologies, therefore, are absolutely essential to mitigate the strain. Early diagnosis is crucial as it leads to more effective care and improved outcomes. NHS England estimates that fewer than 2/3 of people with dementia in England have received a formal diagnosis. However, achieving such diagnosis is vital for enabling patients and their family members to accept the condition and seek appropriate support. And in turn, early detection plays the key role in reducing the economic burden and minimizing the negative impact on healthcare systems. It's also important to remember that accurate diagnosis facilitates the inclusion of patients in clinical trials for disease-modifying treatments. It supports the monitoring of trial effectiveness and also aids in predicting the rate of disease progression. Dementia is a very complex condition, with only around 60% of cases attributed to the most commonly known Alzheimer's disease, while many other forms also exist. And on that note, it would be very important for me to touch upon the classification of neurodegenerative conditions. Broadly speaking, they can be grouped into dementia and movement disorders, with dementia disorders further clinically subgrouped whether the patient presents predominantly with memory impairment or behavior disturbances. But from pathology point of view, we are looking at the neurodegenerative diseases based on the protein misfolding and aggregation. And there are 5 common proteins, which are normal physiological proteins, which under unknown circumstances can change their shape and accumulate in the brain and cause neurodegenerative condition. They can accumulate in neurons, they can accumulate in extracellular space, and they can accumulate in glial cells. And depending on the combination of different types of misfolded protein and which cell types affect, different diseases will occur. For example, if there's a combination of amyloid beta and tau pathology, it's Alzheimer's disease. If it's the misfolding of physiological prion protein, that will lead to the prion disease. If it's misfolding of either tau or TDP43 proteins, it will lead to a condition called frontotemporal lobar degeneration. But even alpha-synuclein pathology, which commonly is associated with Parkinson's disease, can lead to clinical dementia, really highlighting this very importance, how dementia is a complex disorder. And whilst for prion disease, amyloid beta and tau combination, that is Alzheimer's disease, and for alpha-synuclein pathologies, there are just 1 or 2 further disease phenotypes based on the misfolded protein pathology. For tau pathology, there are actually many more underlying diseases. So for example, if the misfolded protein accumulates in neurons in a specific shape, it's called Pick's disease. If it accumulates in the dendrites of the neuronal process, it is argyropathic grain disease. If the same globular inclusions are seen in a different cell type, oligodendroglial cells, the disease is globular glial tauopathy. If the hallmark pathology is in astrocytes in a specific conformation, it's progressive supranuclear palsy. If in a further separate distinct conformation, it's corticobasal degeneration. And also chronic traumatic encephalopathy, hallmark pathology, is astrocytic tau pathology, but it was very different conformation of the misfolded tau pathology. And the same is for the TDP43 protein. It can misfold in at least 5 different conformations, leading to 5 different diseases. And so what about the availability of biomarkers for this very vast range of dementia types? So if you look at the CSF and plasma for diagnosing these diseases in living patients, for prion disease, yes, there is a CSF-based seeding aggregation assay, but there is no blood-based marker. For Alzheimer's disease, yes, there is a CSF-based assay, which is looking at the amyloid beta and tau ratios in the CSF. And there is also an assay which is looking at phosphorylated tau at threonine 217, which can be detected in plasma. The same for Lewy body disorders, alpha-synuclein. There is a seeding aggregation assay available, but there is no blood-based biomarker available. And for the wide range of these tauopathies, there is, at this very moment, there is no CSF or plasma-based marker or even imaging-based marker available. And the same for TDP43 proteinopathies. At this stage, the diseases cannot be very accurately diagnosed using any diagnostic tools in a diagnostic setting in a living patient. It very much purely depends, the diagnosis is based on the clinical phenotype, which is not accurate at all. So, but when now we look at the biomarker availability in NHS setting, you can see that the picture is way, way more grim. At this very moment, it's only the CSF ratio markers available in the NHS setting. Although I just show you that for Alzheimer's disease and prion disease, there is also either CSF or plasma-based marker available. But there is a green light, there is a light at the end of the tunnel, in particular in relation to the Alzheimer's disease and blood-based biomarker, this phosphorylated T217 plasma cell marker. So very quickly to highlight these differences. So for the CSF, this marker is not widely available across the NHS Trust, yet it is available in the United Kingdom through the National CJD Research and Surveillance Unit. The blood-based biomarker for Alzheimer's disease, which really is far superior over the CSF-based testing because it's going to be much more easily accessible and therefore easy to use in general practice. Unfortunately, it's not available through NHS. However, as of beginning of this year, it is offered as part of a large research trial, one of those trials called ADAPT, Alzheimer's disease diagnosis and plasma phosphorylated tau at threonine 217 measurement. And the reason why these trials, these clinical trials are required prior these markers can be included in NHS practice is because whilst at the research level, it's been shown that this is a very promising marker, a biomarker for disease diagnostics, one still needs to demonstrate in real life situation the test accuracy, its real cost effectiveness, and ease of use. And this really brings us to the fact that there indeed are still barriers which hinder the adoption of new diagnostic tests within the NHS. One of those is the diverse mechanisms underlying various dementia types, which complicate the pathway to comprehensive and straightforward diagnostic solution. It's also the lengthy clinical validation and regulatory approval processes, which further delay the introduction of new technologies. It's the integration of these technologies into existing NHS frameworks, which present additional challenges, as for example, as I mentioned, one of those markers for prion disease or Lewy body disorder diagnostics is a seeding aggregation assay, which is not used for any other tests and is a very novel approach and diagnostic tool how to diagnose a disease. And it's also, most importantly, the insufficient resources to support research validation and widespread implementation of diagnostic methods, which add to these challenges. So therefore, the collaborative efforts with industries are absolutely critical to overcome these barriers. This includes supporting ongoing research to develop novel tests and also extend the research efforts to include less common forms of dementia. It's addressing the regulatory hurdles related to test validation which can be facilitated through shared standardization protocols, harmonized reporting systems, alongside data sharing platforms. Addressing the technical challenges must be done, and this can be ensured by seamless integration of new tests into current NHS systems, and by importantly providing education and training both to the laboratory staff and clinicians on test usage, interpretation, and even sample accurate and preparation. Tackling funding and resource constraints requires building partnerships amongst government bodies, private entities, and public sectors, which only in that way can really enhance funding and optimize resource allocations. And collectively, through collaborative work with academia and industry, advancing diagnostic technologies, streamlining regulatory processes, and ensuring effective implementation will eventually contribute significantly to reducing the burden of dementia on NHS and society as a whole. And yeah, and on this note, I'll finish, and I understand we'll take the questions afterwards.
Thank you very much, Jana, and apologies for mispronouncing your name. I should have asked you about that beforehand. Thank you very much for that. If I could ask the next speaker now to move on and share the screen. As Jana said, we are inviting people to post their questions in the Q&A box, and we'll hopefully get to some of them at the end. So our next speaker is Ian Godber, who is a clinical scientist working out of Glasgow, based in biochemistry, and he's going to talk to us about similar issues around diagnostics and heart disease. Thank you, Ian.
Thank you very much, Bernie. Yeah, I'm going to focus on heart disease and particularly heart failure, and look at the funding issues and potential inequalities that we've observed across the UK. My background about myself. I'm lead clinician for biochemistry in South Glasgow. I'm former clinical lead for the biochemistry for NHS Lanarkshire, one of the other health boards in Scotland. Past chair of the Scottish Clinical Biochemistry Network, and currently the chair of the RCPath Specialty Advisory Committee for Clinical Biochemistry, and soon to take up the presidency of the Association for Laboratory Medicine. So there's a bit of background there on how I've got involved in things like introduction of new tests and funding mechanisms for them. So a little bit about heart disease in the UK. Oops, sorry, move back to that slide. So heart failure is an important public health issue affecting many millions of people in the UK. The mortality risk remains high despite improvements in therapeutics over a number of years now. And there's a projected 46% increase in prevalence over the next 6 years. What we've observed are diverging trends and inequalities in admission to hospital amongst these patients. And this is also affected by the socio-economic status and where they're coming from. So hospital diagnosed patients, in summary, have a significantly poorer outcomes than those diagnosed in the community. So this is a disease where early pickup and early treatment can help your outcomes. I would encourage people to have a look at this. This is a British Heart Foundation UK fact sheet from this year, which describes a number of facts about heart disease in the UK. For those who know their geography, you can see the little dark red patch that is Glasgow, which has the highest prevalence of heart disease in the UK. And the total cost, whilst the costs are not as high as Nick's antimicrobial resistance costs, the costs in the UK, the annual cost of heart disease and circulatory diseases in the UK has been estimated at £12 billion. So there is a large amount of money being spent on the care of patients with heart diseases. So, as I've said, there are big issues with delayed diagnosis in the community, for heart disease. Delayed diagnosis is leads to most patients presenting at the hospital with a first diagnosis rather than in the community, which is obviously associated with increased mortality. Around 80% of heart failure diagnoses in England are made in hospital, despite 40% of the patients having symptoms that should have been triggered earlier. So really what we've got here is a requirement in an improvement in community diagnosis, and this will require access to diagnostic tests. And what I'm explaining here is a test that has been around for a long time, and the evidence has been established, and that is NT-proBNP. So data from January 2023 shows that nearly 165,000 patients in England waited for an echo test, and that's up 3% since January 2022. So a number of these were waiting over 6 weeks. So what evidence is suggesting that the best way of delivering these echoes is using NT-proBNP as a triage tool. This has been reviewed by NICE in their 2018 guidance. So a number of things were proposed in the 2018 guidance. Measurement of NT-proBNP is recommended. High levels carry a poor prognosis, so refer patients based on the BNP results. Refer patients with suspected heart failure with an NT-proBNP to have specialist assessments and transthoracic echocardiogram within 6 weeks. Can we achieve this though? So there were a number of other factors to say that NT-proBNP less than 400 in an untreated person makes heart failure a lot less likely. The level of serum natriuretic peptide doesn't differentiate between heart failure and reduced ejection fraction, and heart failure with preserved ejection fraction, and a number of other factors are there presented within that guideline. So I asked one of my consultant colleagues in cardiology, what are the key issues with not having full access to BNP? Within our My Health board, we have access to NT-proBNP within the primary care. However, it's not universally accepted in secondary care because of funding issues. Other health boards in Scotland have different access. Some have it available in secondary care, not primary care. Across the UK, there is variation in practice and availability of NT-proBNP, which do make pathways vary from one place to another. So I asked one of my colleagues here in cardiology, what are the key outcomes that BNP is affecting, access to NT-proBNP is affecting? And they replied that access to appropriate diagnostic tests in primary care and setting varies, as I've just said. The wrong treatment. If we don't identify heart failure early, sometimes patients are diagnosed with COPD and given steroids. Patients are transferred to the wrong clinical area. Cardiologists and heart failure specialists are evolving late in care, and sometimes patients are not entered into clinical trials at an appropriate stage when NT-proBNP is an entry requirement. So why do we have this inequality? Well, it comes down to cost. It is an expensive test in terms of biochemistry, but guidance has been introduced, such as the NICE guidance, without funding in place. And this goes for a number of tests where the evidence is there, but the funding isn't. Business cases are difficult to quantify for NT-proBNP, because where are the savings made? Well, the savings are made out in the community, in the health of those patients. Savings could be made in echoes. However, when you actually think about that, the echocardiogram is still there, it is funded. The clinic time is still there and funded. Cardiologists, physiologists, sonographers are still there. What you're doing is not reducing the numbers of those, but you're increasing their efficiency. They're seeing patients quicker, but there's no savings to be made. So that makes the business case very, very difficult. The financial structure isn't in place. And this is what we really need to think about. Diagnostics is demand-led. This will increase. So how are we going to fund it? Are we going to cross-charge primary and secondary care? That's been done in the past. The model in Scotland makes that very difficult because we're health boards and primary and secondary care all come out the same budget. England's moving towards a similar structure with pathology networks. So that cross-charging is going to become more difficult. And obviously, the block contracts that will be in place are going to make that more difficult. So, as I've said, cross-charging the requester is not sustainable and leads to inequalities. So, we need to look at developing funded pathways for key conditions. We need to look at the whole patient pathway. We need to utilise the guidance, and we need to work right from primary care through the diagnostic process and into secondary care. There are examples of where this has worked. Detect Cancer Early was a program in Scotland in 2012, and this was new funding for the introduction of FIT testing for colorectal cancer. It worked. It was new funding, though. Other trials have come in. They often come with short-term funding. Placental growth factor, neuron-specific NLAs, both tests that have been introduced in biochemistry in short-term trials. But the sustainable funding hasn't been there. But we can use that information, we can use that data to inform business cases. We need to look at other sources of funding. Where can savings be made? There was a project I was involved in Scotland a few years ago, which looked at C-peptide. And based on the work of Mark Stratton in Edinburgh, 5%, who concluded that up to 5% of type 1 diabetics could be taken off insulin if they had residual C-peptide present. And retrospective measurement of C-peptide in the type 1 diabetic population made significant savings on the prescribing budget. But there was no mechanism for movement of the funding from prescribing into diagnostics. So we need better links with government and NHS policymakers. There's a role for the college in this. There's a role for associations and the link to partners with the IBMS, LabMed, BIVDA, ABHI. We need to be working together. We need to link with patient organisations. BHF, I presented their data today. They have a lot of data. They have a lot of information, and they have a lot of direct links to patients. So we need to develop this infrastructure. We need to do it now. That's me. Thank you.
Thank you very much, Ian. If I can ask the other speakers to put their cameras and mics back on, and can I also welcome Ashton Harper and Jackie Young from Roche to also join us for this short discussion session. We've got a couple of questions that come in from attendees. If I could just start with a question around where we are today within the NHS, given the terrible position it's in terms of workforce, in terms of funding. But there is some potential light at the end of the tunnel, perhaps, with the development of new plans, notably NHSE's proposed 10-year plan, which is open for input and consultation. What do you think we should be saying to government around the three shifts of healthcare, notably, to paraphrase one of the questions online, given that there's a focus on prevention, and a lot of the stuff we want to do with diagnostic tests is detect disease earlier so we can do something about it? Who wants to go first on that one?
Perhaps from the neurodegenerative disease point of view, I think it's very important to sort of realize that whilst we all, of course, the main key thing, what we all want is to prevent dementia. First, inevitably we need to be able to diagnose, which we cannot currently do in 100% of cases. So before we can find the ways how to prevent neurodegenerative condition, that is dementia, we need to be able to diagnose. And if we will be able to diagnose it early, as the current research studies already show that there is a potential to do that, that's where we can use the disease-modifying treatments, which are also increasingly coming into play, which are actually working. Then with disease-modifying treatments, that's where we will be able to stop the dementia progression.
Okay, thank you.
Sorry, Nick.
No, sorry to butt in. I was just going to say that really the principles are the same in the AMR field. I mean, obviously, an infection that does not occur requires no antibiotic treatment and will not lead to the development of resistance. So prevention is absolutely key in the AMR field. I think that there are some really interesting examples of where almost the natural experiment that occurred during the pandemic led to changes in the incidence of some infections, and the measures we took in hospitals to prevent COVID had a beneficial knock-on impact on many healthcare-associated infections, which reduced in incidence, and there are data to show that antimicrobial resistance in some key pathogens reduced as a consequence of that. So I think prevention in the AMR field is everything. An infection, as I say, that does not occur does not need treatment.
Thank you, Ian.
Yeah, no. As well as prevention, I think the whole diagnosis of very early disease in the community is extremely important. And we've got plenty of evidence on the benefits of picking up diseases like heart disease, and liver disease is another one that, if it's picked up early, can be treated in the community, prevents secondary care admissions, and saves the government and us a lot of money. So as you say there, Bernie, we need to be responding to the government's 10-year plan. We need to be stating that early diagnosis and the role of diagnostics in that early diagnosis is extremely important, and it requires its place, but it also requires funding.
Sure.
Sorry.
Yeah.
Just going to build on that.
Yeah, I was just going to ask you actually from the diagnostic industry's perspective, what's the message that you'll be giving government in the NHS portal for the 10-year plan?
Yeah, well, I mean, I think similar. I was just going to build on that to say, I think across all disease areas, whether it's neurodegenerative conditions, heart disease, infectious diseases, I think earlier diagnosis and prevention is clearly critical, both for improving patient outcomes, which is the most important thing, but also, making it more sustainable for healthcare systems financially. There's also an additional benefit, diagnosing diseases earlier and preventing diseases means that we can actually have an impact on decarbonising health and social care pathways, because it's less carbon intensive to treat earlier stage disease. So, and that's obviously another critical aim for the NHS Net Zero. So I think all of these things we're going to be talking to government about, and I fully agree with, when we're really aligned with prevention, early diagnosis, digitalisation, and also care closer to home. And I think all of those will have tremendous benefit.
Yeah, sure. Thank you, Jackie. What's the biggest bit of red tape that frustrates you? And I know there are many.
I think it's just the levers in terms of looking at the incentives. We spoke about silo budgeting, and I think that's one of the big challenges. And we really need to ensure that we've got the appropriate mechanisms to facilitate and ensure that we can truly optimize and transform patient pathways. So one of our asks is obviously sustainable diagnostic funding, but ensuring that can be driven by the appropriate levers and incentives.
Okay, agreed. Thank you. We've got a question from the audience, which I'll fire at Nick. At what point in a potentially terminally ill and rapidly deteriorating patient's trajectory illness do you suggest that we stop IV antibiotics? This is a sort of area that came up in our International Pathology Day discussion on Wednesday at the conference we hosted. And it's really about how difficult it is to get clinicians to stop doing something. What's your opinion on that?
I will be more patient focused, I think. I think it's difficult to give a single answer to this. I don't think there's a definitive point at which you stop, but I would turn it around and say, why would you give antibiotics in a terminally ill patient? Clearly, it's to treat an infection that they've got where that infection is causing symptoms that might cause distress. So they're, at the end of life, it's about ameliorating anything that might cause discomfort and having, depending, as I say, what it is, where the infection is, there may be symptoms that do make the patient feel worse, and so it might be worth treating. The other thing I think to emphasize is that infection is different from any other field of medicine in that what happens in one person can have an impact on somebody else, and therefore, for example, with a pathogen that might cause infection in hospitals, MRSA, for just as one example, it might be beneficial for the other patients in a clinical area to treat a patient to prevent onwards transmission to others. So there are all sorts of factors that you might take into account, but I would make it patient focused.
Thank you. A couple more questions from the audience. Andrew Kerry makes a good point. How can we release funds up front for diagnostic tests? And I guess even in those no-brainer situations where we know a test such as NT-proBNP can have a major impact on patient pathways, very, very stretched patient pathways, how can we design a new model that actually allows us to bypass that bit of red tape? I'll pose that to Ian.
I think that is where I was alluding to on the last slide there. We need to be working together. We've got various bodies such as the college, LabMed, IBMS, the trade bodies, companies. We need to be working together on this and have a single voice that we can influence, because at the moment, we may all be saying the same thing. However, the problem is still there, and it is a difficult one as well with devolved healthcare. There are different structures in place across the country. So having one, we're all facing an uphill struggle basically. So I think working together, maybe using Pathology Alliance as a way forward. I don't know your views on that, but Bernie, from a college point of view.
Yeah, I mean, certainly I would agree that it's a much, much more potent and stronger voice for the profession and industry to join together, both in terms of trying to stimulate and advertise the evidence base, but also to lobby government, to lobby the NHS, to lobby local health areas that have decision-making powers around introduction of tests. Jackie and Ashton, we've seen some diagnostic companies trying to sort of bypass the normal routes, because they don't get anywhere, and go straight to government with the help of, patient groups even. Is that a useful pathway to go down?
Obviously, the patient voice is incredibly strong, Bernie, and I think where we have got tests, for example, NT-proBNP, and where we have got tests that have, gone through, diagnostic guidance, that should come with supported funding and also mandation to implement. And I think that would be a start. And in England, we saw the medtech funding mandate, and that really sort of drove the uptake in terms of, and we've spoken, you know, and I think it was highlighted through a number of the presentations today, that it's not just about the funding, it's also about the behavioural change. It's that whole change management that is actually required to bring about pathway to the transformation. So that would at least be a start in terms of nice diagnostic guidance, you know, being funded and mandated. But yes, there is a voice and there is a role. You know, at the end of the day, if we can diagnose earlier, then we can save a lot on those, you know, downstream, you know, treatment costs that we're spending, and the late interventions, and the societal costs as well, especially, you know, from an Alzheimer's sort of perspective. So I think, you know, absolutely, you know, let's, you know, coalesce together to really bring home, you know, pathology is vital, and that early diagnosis piece, so that money can effectively be saved downstream. But the stronger the voice is when we work together.
Okay, time for just one final question. We've seen an explosion in recent years with direct-to-consumer testing, patients taking it off their own back to go and get diagnostic tests and so on. Is that a route that could be used, especially for the likes of a dementia test, which could be quite popular, but there's obviously issues around that as well? Jana, what do you think about that, offering a dementia test direct to the public and they pay for it?
That is obviously a little bit complicated question, very sort of thought-provoking and a good one, with sort of pros and cons. Certainly there are benefits to that through a private route, if the patient can be diagnosed early. The important part there is that there is appropriate counselling following directly that, if the diagnostic test is positive. So I think if that sort of direct private route also provides that, then that's acceptable. If not, then that is actually very dangerous.
Okay, thank you. Right, we're out of time, so unfortunately, thank you for all the other questions that we haven't got to. But I'd like to thank all the speakers for taking part. I'd like to thank Roche for collaborating with us on this webinar, and also thank all of you who attended today. So thank you and goodbye from us.